Assalamualaikum everyone and welcome back to OBG with Sadia Idrees. Bismillahir Rahman Rahim. Today we have reached the fourth and the final part of our Intrapartum Care lecture based on NICE guideline, and I think this is probably the most practical part of the entire series because today we are going to move through labor almost exactly the way you would manage a woman clinically. We will start with a very simple question. Is labor progressing normally? If yes, what should I do? And equally important, what should I not do? Then we will move to delay in labor. How do I suspect it? How do I confirm it? When should I perform amniotomy? When do I need oxytocin? And later we will move into second stage perineal care, third stage postpartum hemorrhage, and immediate care after birth. So today I want you to think like the clinician looking after the woman, not simply like a student memorizing a guideline. At every step, ask yourself, is this normal? Is there a problem? And if there is a problem, what is the least intervention required to manage it safely? Keep that framework in your mind throughout this lecture. So let's begin. Before we start, just look at the slide. Yes, there is a lot here, but don't get overwhelmed because essentially today's entire lecture follows the natural journey of labor. We began first with first stage, its expected duration, its normal progress, and how to recognize delay. Then comes our first major intervention, amniotomy. If that is not enough, we move towards oxytocin, and this is where counseling, CTG monitoring, titration, and uterine stimulation, hyperstimulation becomes extremely important. Then the cervix becomes fully dilated, and we enter the second stage. Here, we will distinguish passive from active second stage, discuss pushing, maternal position, fetal monitoring, delay, and when birth may need to be expedited. And after that, baby is born, our responsibility does not end. We assess the perineum, recognize and classify trauma, repair appropriately, and provide good post-repair care. Then comes the third stage, followed by most important obstetric emergency postpartum hemorrhage. And finally, we will talk about communication, documentation, and immediate postnatal care. So think of today's lecture as one continuous journey. Progress, then recognize delay, then intervene for a reason, then deliver safely, protect the mother after birth, and that is our roadmap. So, okay, let's start with a number question. And this is exactly the kind of thing that can appear in an exam question. How long should the first stage of labor actually last? First, remember that parity matters. For a woman in first labor, the first stage lasts on an average of about 8 hours and is unlikely to last longer than 18 hours. For a woman in her second or subsequent labor, it is usually faster, average around 5 hours, and unlikely to last longer than 12 hours. Now, don't mix these four numbers. I want you to remember that as two pairs. First labor 8 and 18, and subsequent labor 5 and 12. 8, 18, 5, 12. These are very easy SVA numbers, but clinically don't look at the clock alone. Labor progresses not simply she has been labor for this much hours, therefore something must be wrong. You need to look at the cervical chain, the contractions, the descent, the rotation, the parity, and the overall condition of the mother and the baby. That brings us to a much more important principle. This slide contains one of my favorite principles of intrapartum care. Normal progress, don't interfere with it. Sometimes in obstetrics, we become so focused on doing something that we forget that doing nothing unnecessary is also good clinical management. If labor is progressing normally and both mother and baby are well, NICE says to not routinely intervene. That means we do not routinely perform amniotomy because the membranes are still intact. And we do not really use a combination of early amniotomy and oxytocin just to accelerate labor that is already progressing normally. So imagine an exam question: a low-risk woman is in established labor. Maternal observations are normal. Fetal condition is reassuring. The cervix is progressing appropriately. Membranes are intact, and one option says perform unnecessary. Normal progress does not equal ARM plus symptom. Your management this works beautifully with respectful maternity care. Intervene because there is a now. Suppose you feel labor is not progressing as expected. Before labeling the woman as having delayed labor, stop and assess the situation properly. Think of four things. First, the parity. Is this her first labor, or has she delivered before? Because expected progress is not identical. Second, look at the cervix. What is the current dilatation? And more importantly, what has been the rate of change? One isolated cervical examination gives you a measurement. Two apparently time examination gives you progress. Third, assess the contraction. Ask how frequent are they? How long do they last, and how strong do they appear clinically? Because poor uterine activity may explain poor progress. And fourth, assess the presenting part. What is the station? Is there a descent? What is the position? Is rotation occurring? A cervix that is not dilating is only part of the picture. A persistent malposition or failure of descent may be telling you why labor is not progressing. And while you are investigating the labor, don't forget the woman herself. Provide support, hydration, and effective analgesia. This is the woman going through a labor, not a cervix attached to a CTG machine. So suspected delay should trigger assessment, not an automatic oxytocin infusion. Okay, now we come to another very important numerical point. When should we actually suspect delay? In the established first stage. In a woman in her first labor, suspect delay if cervical dilatation is less than 2 centimeters in 4 hours. For a woman in her second or subsequent labor, consider the same threshold. Less than 2 centimeters in 4 hours, but also take into account whether her progress is slowing down. And please notice the word I keep using, suspect, not immediately diagnose. That distinction matters. Less than 2 centimeters in 4 hours raises the concern. It tells you something may not be progressing normally. I need to reassess this woman properly. So for your exam question, less than 2 centimeters in 4 hours, suspect delay. Don't jump directly from this number to oxytocin. There is another step. So now imagine the cervix has progressed by less than 2 centimeters over 4 hours. What next? Do we immediately write failure to progress to start oxytocin? No. First, discuss your findings with the woman. Explain that progress appears slower than expected and discuss the available options. Continue supportive care. Make sure she has adequate hydration, support, analgesia. Then repeat the vaginal examination 2 hours later. If cervical dilatation has increased by less than 1 centimeter during those 2 hours, then delay is diagnosed. So remember the sequence. 4 hours, less than 2 centimeters, suspect delay. Then another 2 hours, less than 1 centimeter, diagnosed delay. That's a beautiful memory line. In 2 hours, less than 1 centimeter, it is delay. And this distinction becomes between suspected and confirmed delay is exactly the kind of detail examiners love. Okay, now we have confirmed delay. Next question. Are the membranes intact? If yes, consider amniotomy. But notice the word I not say every is considered amniotomy. And pause is an intervention. Counseling matters. Explain to the amniotomy may shorten labor by approximately 1 hour. But also tell her the other side. Contractions will become more stronger and more painful after the membranes are ruptured. So you're not simply saying progress is slow, I'm going to break your waters. You're involving the woman in the situation. This is what? Yes, please, shared decision making. For exams, however, the association is beautifully simple. Confirmed delay plus intact membrane, consider artificial rupture of membrane. Notice how different that is from our previous slide. Normal progress plus intact membrane does not routinely AR. That contrast is extremely important. Now here is the little suppose delay has been diagnosed and amniotomy is being considered. Does performing ARM itself mean that she must automatically be transferred to obstetric-led care? No. No. Amniotomy alone is not an indication for automatic transfer to obstetric-led care. And this is worth remembering because students often associate any intervention with escalation of the place of care. Not necessarily. The indication for transfer depends on the clinical situation, not simply on the fact that membranes were artificially ruptured. So exam line is ARM alone does not mean automatic transfer. Very short, very testable. Okay, now let's complete the because this is where everything starts connecting. Membranes were intact. We perform amniotomy. Now what? Again, we don't immediately jump to oxytocin. We give labor an opportunity to respond. Perform a repeat vaginal examination 2 hours after amniotomy. If progress has occurred, excellent. Continue appropriate care. But if there is no progress, then delay is confirmed. And the woman should be transferred to obstetric-led care. So look at the sequence. Yes, no progress, then diagnosed delay, then transfer to obstetric-led care. And compare this with previous slide. That ARM alone does not mean automatic transfer, but ARM, and now 2 hours had happened, and now no progress. Now transfer to obstetric-led care. That difference is absolutely worth remembering. And now we have reached the point where the next clinical question becomes, what if amniotomy is not enough? This is where oxytocin enters our pathway. So we have performed amniotomy and reassessed the woman. And unfortunately, labor is not progressing. What is the next step? This is where we move to obstetric assessment. And please notice something, that the next step is not oxytocin. Please notice that before oxytocin, we need to understand progressing. The obstetric assessment should include and a vaginal examination. On an examination, think about the lie, the presentation, the position, the descent. This is the vital dilatation, station, position, caput, and molding the relevant. Why? Because oxytocin can improve inadequacy. It can problem. If the baby or vaginal birth is unlikely to be safe. Simply making the uterus contract harder is so your exam sequence is that if there is confirmed delay, there should be obstetric assessment, then consider oxytocin. That word assessment between delay and oxytocin is important. Now suppose obstetric assessment has been performed and oxytocin is being considered. Before starting it, we need a proper discussion with the woman. what can oxytocin actually achieve? It can increase the uterine activity and make the time of birth. But this is a very important counseling point. It does not necessarily improve the mode of birth or neonatal outcome. So don't sell oxytocin as we'll start the drip and then everything will definitely be fine and you will definitely deliver vaginally. That's not appropriate counseling. Instead, explain the medication makes contractions stronger and frequent, and it may help labor progress and bring forward the time of birth. And because contraction becomes stronger and more frequent, this as a consequence. Oxytocin requires continuous CTG monitoring. Why? Because excessive uterine activity can compromise fetal oxygenation. So remember the physiology rather than memorizing an isolated rule. Oxytocin causes stronger, more frequent contraction, the potentially fetal effect. So we need continuous CTG. That chain makes the recommendation much easier to remember. And this is something I really want you to take into your clinical practice. Oxytocin is not simply a prescription written on a chart. It is a shared decision. If after counseling, the woman decides to start oxytocin, we support that decision. But equally decision about stopping or restarting oxytocin should involve her as well. And pain relief needs to be a part of this discussion because we have just told her that contractions may become stronger and more painful. So NICE recommends offering an epidural before oxytocin started or later if she requested. Now be careful with the wording. Offer epidural. Not you are starting oxytocin, therefore you must have an epidural. No, she may accept it, she may decline it, she may initially manage without it and request it later. So the example is offer epidural. Don't impose epidural. This is exactly what respectful maternity care looks like in practice. Now, here is a small point that can make a surprisingly good SPL. We have started an oxytocin infusion. Does that mean we should automatically put an additional IV fluids? No, do not generally give separate IV fluids simply because oxytocin is being administered. Use IV fluids when they're clinically indicated. For example, if the woman is not drinking adequately, is dehydrated or hypotensive, then of course fluid may be required. And while oxytocin is running, pay attention to the fluid balance. And while oxytocin is running, pay attention to the fluid balance. This matters because oxytocin has an antidiuretic effect, particularly with prolonged administration and excessive fluid intake. So inappropriate fluid administration can contribute to fluid overload and hyponatremia. So the practical message is oxytocin does not equal automatic extra IV fluids. Assist the woman, give fluids for an indication, not as a reflex. Okay, everybody, pause here. SBA numbers. If you are revising this lecture the night before the exam, this is one of the slides you should come back to. When increasing oxytocin, increase it no more frequently than every 30 minutes. And what are we trying to achieve? Approximately 3 to 4 contractions in 10 minutes. Not as many contractions as possible. More contractions are not automatically better. Our aim is effective uterine activity without excessive uterine activity. So memorize this as one line. 30 minutes, target 3 to 4 contraction in 10 minutes. So if an exam question gives you options that is increasing oxytocin every 10 to 15 minutes, be suspicious. The aim is controlled titration, not chasing labor with increasingly frequent dose changes. Am I clear so far? Now, let's imagine oxytocin is running and the CTG becomes pathological. What should you do? This is not the moment to say, let's just reduce the infusion slightly and see what happens. Stop oxytocin immediately. Then obtain urgent review by an obstetrician or senior midwife and manage the abnormal CTG appropriately. Why stopping oxytocin such as immediate step? Physiologically, every uterine contraction temporarily reduces the uteroplacental blood flow. Oxytocin increases the uterine activity. If the fetus is already showing the evidence of compromise, continuing to stimulate the uterus may worsen the situation. So, an exam question, if oxytocin is running and pathological CTG, stop oxytocin now. Don't overthink that one. Now, here is a natural follow-up question. We have stopped oxytocin because the CTG became pathological. The CTG subsequently improves. Can we restart oxytocin? Potentially, yes, but not casually. Consider restarting only after an obstetric review when the CTG is no longer pathological and after discussing this with the woman and obtaining her agreement. And don't automatically jump back to whatever dose was previously running. The restart should be based on the full clinical assessment, including the previous dose and the current uterine activity. So the memory line is that review the woman. If CTG improves, woman agrees, consider restart. This also shows you something very important. Starting oxytocin is not irreversible. Stopping it is not a failure. And restarting it is not automatic. At every stage, management responds to the condition of the mother, the condition of baby, and labor. Now, the oxytocin is running and regular contractions has been established. How do we know whether it is actually working? We reassess the cervical progress. Once regular contractions are established, perform a vaginal examination 4 hours later. Now divide the result into two possibilities. If cervical dilatation has increased by 2 centimeters or more, good. We have evidence of progress. Continue the management and subsequent vaginal examination approximately 4-hour intervals, and unless there is a clinical reason to examine earlier. But what if dilatation is increased by less than 2 centimeters in those 4 hours despite oxytocin? That should trigger further obstetric review. Am I clear so far? At that point, reassess the whole clinical situation and consider whether cesarean birth is advisable. Notice the language again. Not every woman who fails to achieve 2 centimeters immediately goes straight to theater without assessment. It is less than 2 centimeters. Further obstetric review. Consider whether cesarean birth is advisable. Another lovely exam number. So now all the numbers together in 30 minutes, minimal interval between the dosal increments, 3 to 4 means that cervical target contraction frequency in 4 hours assess the cervical progress. If more than 2 centimeters, then satisfactory progress. Am I clear so far? These 4 numbers are worth knowing. Now, with that, we are finally leaving the first stage behind. The cervix reaches full dilatation. So surely second stage has started. Yes, but here's the interesting part. Does full dilatation automatically mean the woman should immediately start active pushing? Not necessarily. And this brings us to a distinction students very commonly confuse passive versus active second stage. The passive second stage begins when the cervix is fully dilated, but the woman is not yet actively or involuntarily pushing. This distinctions become particularly relevant when a woman has an epidural. Am I clear? Imagine she's fully dilated, comfortable with her epidural, and has no urge to push yet. That does not mean something has gone wrong. There may be a period during which the presenting part continues to descend before the active pushing begins. So here is an example. Full dilatation does not necessarily mean active second stage. Full dilatation tells you the second stage has begun. But to call it active second stage, we need something more. So when exactly does the active second stage begin? This definition is worth learning properly. Active second stage is when the cervix is fully dilated and one of the following occurs. The baby becomes visible, or there is involuntarily or active pushing. So don't reduce second stage to one sentence. 10 centimeter means start pushing. Clinical reality is more important. Think full dilatation alone without pushing. It means think full dilatation alone without pushing is passive second stage. Then baby visible or involuntarily active pushing, it is active second stage. And this distinction becomes matches because when we later discuss the expected duration of the second stage, maternal observation, assessment of the progress, and when to diagnose, so you need to know which clock you are actually clocking. So now we have entered the second stage of labor. Remember that our assessment does not stop simply because the cervix is fully dilated. In fact, even more and fetal well, we assess the progress of the vision and of the presenting part. Once active pushing begins, also assess whether the pushing is actually effective. Is there progressive descent of the fetal head with maternal effort, or is the woman pushing for a long time without any meaningful progress? And please don't forget the woman herself. Second stage can be physically exhausting and psychologically overwhelming. So our emotional and psychological needs remain an important part of the intrapartum care. One important change now is fetal surveillance. As labor progresses into second stage, the frequency of fetal heart rate monitoring increases. And that brings us to a very important exam number. So here is your next SBA number, 5 minutes. Remember this thing. If the woman is being monitored by intermittent auscultation during second stage, auscultate the fetal heart rate immediately after a contraction for at least 1 minute and do this at least every 5 minutes. So remember, after the contraction for at least 1 minute, at least every 5 minutes, but there is another important 5-minute assessment here. The maternal pulse should also be palpated every 5 minutes. Why? Because particularly during second stage, there's a risk of accidentally confusing the maternal pulse with the, yes, please, fetal heart rate. So if an exam question asks how frequently fetal heart rate should be auscultated in second stage, think, yes, please, 5 minutes. Again, maternal pulse, 5 minutes. And that is a beautiful little exam pair to remember. Now, what about vaginal examination? Once the woman is in active second stage of a vaginal examination, hourly. So compare this with first stage, where we usually talk about 4 hourly vaginal examinations. In active second stage, the interval becomes much shorter. Vaginal examination every 1 hour. Of course, it can be offered earlier if there is a clinical indication or according to the woman's wishes. And at this stage, don't just document that cervix is fully dilated. You need information that tells you whether the baby is actually progressing through the pelvis. Assess the position of the fetal head, the descent, the caput, and the molding. This is particularly important if progress appears slow because these findings may influence subsequent obstetric decision making. So another exam number, active another important thing. Now let's discuss something very practical, maternal position during adapt position that are comfortable for them, but prolonged lying flat on the back should be avoided. Why? Because the gravid uterus and this so don't automatically put every woman flat on her back just because she has reached the second stage. Encourage a comfort. Oh, the woman has again, it not mean supine position. Please, that is an important section. Clear this in your mind that women can be encouraged to adopt a lateral position, and that this may increase the chance of spontaneous vaginal birth. Choose an upright or another comfortable position. Obviously, safety comes first, particularly if motor block limits mobility. But the key message is that the epidural does not automatically mean lying back on our flat on our back. Remember that for clinical practice and for your exam question. Now consider a woman without an epidural. Here we should actively encourage mobility and allow the woman to adopt the position she finds most comfortable. This could include an upright position, kneeling, squatting, leaning forward, or birth stool or seat position. Now, why are we interested in these positions? Because compared with lying supine, upright and mobile position may improve the woman's birth experience and may be associated with reduction in some adverse outcomes, including fetal heartbeat abnormalities and episiotomy. So don't think of second stage as full dilatation, put the push in the thoracotomy, start pushing. Modern intrapartum care is much more individualized than that. Allow movement, support maternal choice, and avoid unnecessary restriction. Now, here comes a very interesting clinical scenario. The cervix is fully dilated. The woman does not have an epidural, but she says, I don't feel the urge to push. What should you do? Do we immediately start directed pushing? No. Do we immediately diagnose second stage delay? No. If there's no urge to push, continue appropriate observation and perform a further assessment after 1 hour. During this period, continue assessing the maternal and fetal well-being, contractions, the progress, and the position and the station of the presenting part. So the exam number here is that if there's no epidural and no urge to push, then further assessment after 1 hour will be. So now here comes a very important slide, and I want you to remember this thing. See, if we talk that the cervix is now fully dilated, but no urge to push, we have discussed. Now, the thing is that things are now slightly different if the woman has an epidural. This is another area where numbers become extremely important. For a nulliparous woman with an epidural, directed pushing may be delayed for up to 2 hours after full dilatation, unless she develops an urge to push earlier. For a multiparous woman with an epidural, directed pushing may be directed for up to 1 hour. So here is your memory line: nulliparous woman 2 hours and multiparous woman 1 hour. But delayed pushing does not mean delayed care. Throughout this period, you must continue assessing the maternal well-being, the fetal well-being, the progress, the contractions and fetal position and station. This distinction is very exam friendly because examiners may give you a woman with an epidural who is fully dilated and ask when directed pushing should begin. So remember, for epidural in nulliparous women, the directed pushing may be started for up to 2 hours and multiparous delayed for up to 1 hour. Now, imagine that active pushing has started but does not appears to be effective. A common mistake is to jump immediately to she needs an instrumental delivery. Not necessarily. Before escalating to operative birth, first look for simple correctable factors. Provide support and encouragement. Review her pushing techniques. Consider a change in position. Make sure the bladder is empty because a full bladder can interfere with the descent of the presenting part. At the same time, reassess the contractions, the fetal position, the station, the descent, and fetal well-being. So remember, ineffective pushing does not automatically equal immediate operative birth. First, assess why the pushing is ineffective and address the reversible factors. Now we move into perineal care, and there are some very practical recommendations. Once the presenting part begins to distend the perineum, offer a warm, wet compress to the perineum. Continue this until birth, ensuring that the temperature remains comfortable and safe for the woman. Alternatively, consider the perineal massage using a water-soluble lubricant if this is acceptable to the woman. Some women may prefer massage instead of a warm compress. So again, shared decision-making matters. And remember an important exception, these interventions are not applicable during water birth. So the exam takeaways presenting part distending the perineum, warm wet compress, or consider perineal massage with water-soluble lubricant. The aim is not simply to protect the perineum by doing more procedures. The aim is to use evidence-based measures that may reduce significant perineal trauma while maintaining the woman's comfort, dignity, and choice. And now that we have discussed prevention of perineal trauma, the next logical question is, what about episiotomy? Should we perform it routinely? Absolutely not. And that is what we are going to discuss next. Now let's come to episiotomy. And the first thing I want you to remember is very simple. Routine episiotomy is not recommended. During spontaneous vaginal birth, we do not perform an episiotomy simply because the woman is primigravida, because the perineal lobe is tight, or because we routinely perform one in every first delivery. Episiotomy should have a specific clinical indication. Examples include an instrumental birth, forceps or venous birth, or when the birth needs to be expedited because of suspected fetal compromise. And before performing an episiotomy, provide effective analgesia, except obviously in acute emergency where immediate birth is required. And also remember, lidocaine spray should not be offered routinely for pain relief during the second stage. And now another very testable point is the type and angle of episiotomy. When an episiotomy is performed, a mediolateral episiotomy is preferred. Okay, the incision starts at the vaginal foresheet and is usually directed towards the right side. Forget about it. This is wrong diagram. Right side. And here is your number, 45 to 60 degrees from the vertical axis at the time of episiotomy. This angle matters because an incision that is too close to the midline may increase the risk of extension towards the anal sphincter. So exam goal is spontaneous vaginal birth does not equal routine episiotomy. And if episiotomy is required, mediolateral 45 to 60 degrees. So now we have discussed about the episiotomy. Now we will move towards our another slide. That is, now here's a very common misconception. Suppose a woman had a 3rd or 4th degree tear in a previous delivery. Does that mean we should routinely perform an episiotomy in her next vaginal birth? No. Previous OBS anal sphincter injury does not automatically mean prophylactic episiotomy next time. Instead, future birth planning should be individualized. Discuss her current symptoms. Is she experiencing an previous trauma, the risk of recurrence, how successful the previous repair was, and importantly, the psychological impact of that previous birth. And also review her previous labor was managed. So don't convert pregnant trauma into an it does not mean automatic informed discussion with the woman. So before we move into delayed second stage, let's rapidly bring our important first aid numbers together for a woman in her first labor. Established first stage lasts on average around 8 hours and is unlikely to last more than 18 hours. And for subsequent labor, which is around 5 hours and it is unlikely to last more than 12 hours. When assessing possible 2 centimeter and 4 hours, we suspect delay. Reassess after 2 than 1 centimeter, delay is diagnosed. If membranes are intact, amniotomy can be considered, followed by reassessment after another 2 hours. Dose and number to occur no more frequently than every 30 minutes and aim for approximately 3 to 4 contractions in 10 minutes. And remember, if contractions become excessive, Reduce or stop oxytocin is appropriate, and after starting oxytocin for confirmed delay. In the first stage, recess cervical progress at 4 hours, and we are looking for meaningful progress around more than 2 centimeters. These numbers are worth memorizing because they are perfect exam questions. Now, screenshot this slide mentally because the second stage number one active second stage vaginal examination, number two with intermittent number three maternal every 5 minutes and particularly different fetal heart rate. Number four, fully dilated, no epidural. Reassess after 1 hour with an epidural delayed push and angle it is given for about 60 degrees. If you remember high yield second stage SPA material. Now let's apply those number clinically. Consider a multiparous woman with an epidural. Birth would usually be expected within 2 hours from the start of the active second stage. Remember that before active pushing, she may already have had a passive second stage of up to 1 hour after full dilatation. Once she starts active pushing, don't simply leave her pushing indefinitely. After around 30 minutes of active pushing, ask yourself, is there rotation? Is there descent? Are the contractions adequate? How is the mother and how is the baby? If progress is occurring, continue pushing with appropriate support. But if there's no progress, perform a vaginal examination, and if the membranes remain intact, consider amniotomy where appropriate. If there's still no progress, diagnose and obtain senior obstetric review. And here is the senior find the appropriate place and mode of birth. So don't remember 1 hour in isolation. Remember the sequence that multiparous woman with epidural assess progress after 30 minutes of pushing if birth is not imminent after 1 hour senior review. Now this is an excellent SPA draft. The woman has confirmed delay in the second stage and contractions appear inadequate. Should we just start oxytocin? No. Before considering oxytocin in the second stage, an obstetrician should assess the woman in person. Why? Because inadequate contractions will not be the real problem. First, assess the fetal well-being, confirm the fetal presentation and position, assess the fetal heart rate, and make sure you can distinguish it from the maternal heart rate. Most importantly, exclude the obstructed labor, and then confirm that contractions really are infrequent or ineffective. This is crucial because increasing uterine contractions in the presence of mechanical obstruction is clearly not the solution. Am I clear so far? I hope that it is clear to you now. So if oxytocin is then considered appropriate, increase the dose no more frequently than every 30 minutes, aiming for 3 to 4 contractions in 10 minutes. And during oxytocin use in second stage, continue frequent obstetric review approximately every 15 to 30 minutes. So the exam draft is delayed second stage does not automatically mean oxytocin. First ask, is the baby okay? What is the position? Is there obstruction? Are contractions genuinely inadequate? Okay. Now suppose the birth needs to be expedited for either maternal or fetal reasons. The decision is not simply forceps or C-section. There's several things you need to assess first. Start with the degree of urgency. Then assess the abdominal findings and vaginal examination findings. Ask where is the fetal head? What is its position? What is the station? Is vaginal birth realistically achievable? Then determine the most appropriate mode of birth. If instrumental birth is appropriate, consider whether forceps or venous is more suitable. And very importantly, ask about anticipated difficulty and the likelihood of successful instrumental birth. And very importantly, where should the procedure happen? The location. If there is significant chance of failure requiring immediate cesarean birth, the appropriate location becomes extremely important. Also consider the time required for transfer to obstetric care, the need for additional analgesia or anesthesia, and the woman's preferences. Alongside all this, communicate, explain why birth needs to be expedited, discuss the available option, inform the team of the degree of the urgency, and record the time at which the decision was made. So expediting birth is not just choosing an instrument, it is a structured risk assessment plus communication plus timely action. Now, when should be considered assisted vaginal birth? Forceps or venous may be offered when there is concern about fetal well-being. When the second stage is prolonged or when the woman requires assistance with birth in an appropriate clinical situation. But here is another important point. There's no universal rule that says that forceps are always better or venous is always better. The choice of instrument depends on the clinical circumstances and the experience of the practitioner. Before the procedure, discuss the pain relief options and ensure that analgesia is acceptable and adequate. And of course, the prerequisites for safe assisted vaginal birth must be satisfied. If vaginal birth is not safely achievable, then move birth rather than persisting with an attempt. More birth according to the safety and likelihood of success, not according to the personal habit. This slide is particularly important because modern maternity care is not just about what we can do technically, it is also about shared decision making. Suppose assisted vaginal birth is now recommended, but the woman declines forcible vacuum. What do? We do not simply say fine and C-section. And we certainly don't abandon the discussion. Explain the remaining options depending on the clinical situation. These may include continuing towards vaginal birth, proceeding to C-section, or reconsidering instrumental birth after further discussion. But explain something very important. As labor progresses, the available choices may become very narrow and limited. Why? Because of the clinical safety, the increasing urgency, and the position of the fetal head. For example, in some circumstances, a deeply engaged fetal head may make cesarean section technically more difficult. The Greek principle is respect a decision, explain alternative, honestly, explain the limitation, and continue shared decision making. That's a very nice style SBA concept. Patient's autonomy does not mean withholding clinical information. It means giving the woman the information she needs to make an informed decision. Am I clear so far? And finally, here's a very useful practice training and exam worthy point. After an operative vaginal birth with forceps or vacuum, prophylactic antibiotics should be offered. The recommendation is single intravenous dose of amoxicillin or augmentin given as soon as possible and within 6 hours after cot clamping. So this is not a prolonged post-operative antibiotic course. Think instrumental birth, single IV antibiotic prophylactic dose within 6 hours. If the woman has a penicillin allergy, use an appropriate locally agreed alternative regimen. This is worth remembering because older practice may vary and students sometimes assume that uncomplicated forceps or vacuum birth does not require antibiotic prophylaxis. But for your current evidence-based approach, if this operative vaginal birth, prophylactic antibiotic is recommended, and that brings together a management of delayed second stage from recognizing delay, assessing the cause, deciding whether oxytocin is appropriate, considering expedited birth, choosing forceps, vacuum where appropriate, respecting maternity choice, and finally providing appropriate post-op care. Now we are ready to move towards the third stage of labor. All right, everyone, now we move to the third stage of labor. We have discussed the first stage, the second stage, and the birth of the baby. But remember, delivery of the baby does not mean that the labor is over. The third stage begins from the birth of the baby and continues until the placenta and membranes have been expelled. And there are two ways in which we can manage this stage: active management and physiological management. Am I clear so far? In active management, we routinely manage this stage How do we manage? We give routine nutrotonics, we do cord clamping and cutting and controlled contraction. Is that time for delivery of the placenta? In physiological management, on the other hand, we do not routinely administer a nutrotonic. The cord is not clamped until the pulsation is stopped or the placenta has delivered, and the placenta is allowed to deliver spontaneously or with maternal effort. So conceptually, remember to facilitate the third stage. In physiological management, we allow the normal physiological process to proceed with minimal intervention. And as we move forward, we'll see why active management is generally recommended for most women, particularly because of its effect on postpartum hemorrhage. Now, although the baby has been delivered, this is not the time to stop observing the mother. In fact, the third stage is a particularly important period because significant hemorrhage or maternal deterioration can occur very quickly. During the third stage, record the woman's general physical condition, color, respiration, how she feels, and importantly, vaginal blood loss. And I want you to notice something here. NICE does not simply tells us to look at a number on a monitor. It asks us to assess the whole clinical picture. Is she looking pale? Is she become breathless? Does she feel faint or unwell? Is the vaginal bleeding increasing? Because sometimes this clinical deterioration can become apparent before you have dramatic changes in record observation. If there is postpartum hemorrhage, if there is retained placenta, maternal collapse, or any other concern about maternal well-being, increase the frequency of observations. Assess whether resuscitation is required and transfer to obstetric lecture when necessary. So clinical mindset should be baby delivered, monitoring fluid. No. Continue actively assessing the mother throughout the third stage. Now let's compare the two approaches properly, because this is where counseling and SPA questions become important. Women should ideally be given information about the third stage management antenatally at initial assessment and again during the labor where appropriate. Why? Because this should be part of shared decision making rather than something suddenly done after delivery without it. Active management has some very important benefits. Compared with physiological management, it's associated with lower risk of postpartum hemorrhage, that lower risk of greater than 500 ml pph, a lower risk of pph greater than 1 liter, a lower requirement for blood transfusion, less postpartum anemia, and a lower need for additional nutrotonics. But active management also has potential disadvantages. There may be increased incidence of nausea, increased incidence of vomiting, headache, hypertension, and is in the evidence considered by NICE readmission for bleeding. So when counseling women, don't simply say active management is better. Explain the trade-off. But the major clinical message is very important. Active management reduces the bleeding-related morbidity, and that is why it is generally the recommended approach for most women. Okay, now this slide contains some numbers that I want you to understand rather than blindly memorizing. For pph greater than 500 milliliter, the figures approximately 68 per thousand with the active. That means now 124 women per 1,000 experiences outcome. For it is approximately 13 versus 29 per thousand. For blood, 30% per thousand. Now, you may not necessarily be asked to reproduce every single number in exam. What you absolutely must remember is the direction of effect. Active management significantly reduces bleeding-related outcomes, including pph and the need for blood transfusion. So, if exam question asks which approach to the third, and that is your high yield take-home message. Okay. Now comes an equally important principle, the maternal choice. We recommend active management, but recommendation does not mean that the woman loses her autonomy. If a woman requests physiological management, discuss the individual risk of postpartum hemorrhage, explain the benefits and risks of both approaches in understandable language, allow her to make an informed decision and support that decision. And importantly, document the agreed plan for management of the third stage. So in an exam, don't say the physiological management is unsafe, therefore I will refuse. That should be inappropriate. Instead, say, I will discuss the individual risk factor, explain that active management is associated with lower risk of PPH and blood transfusion, and support informed shared decision making. That sounds much more like consultant level maternity care. The pre-principle is recommend what the evidence support, but respect the informed maternal choice. Am I clear so far? Now let's come to a very practical question. Which Suture should be used for active management after vaginal birth? One option is oxytocin alone, and another option is a combination of oxytocin and ergometry. The combination may be more effective than oxytocin alone in reducing postpartum hemorrhage, particularly when PPH risk factors are present. But there's a price for that additional effect. Oxytocin plus ergometry is more likely to cause nausea and vomiting, and ergometry has important contraindication. This is where your exam antenna should immediately go up. Think about women with hypertension, severe preeclampsia, eclampsia. Ergometry can produce significant vasoconstriction and hypertension, so it should be avoided when hypertension would be dangerous. The slide also highlights severe cardiac, hepatic, and renal disease as situations where the combinations may be inappropriate. So classic SBS situation in preeclampsia or hypertension, avoid ergometry. If you remember only one drug trap from the slide, remember that one. Okay. Now we come to the doses, and yes, these are definitely worth knowing. For active management, immediately after vaginal birth, the Utotonic is given before cord clamping and cutting. One option is oxytocin 10 units intramuscularly. Alternatively, or oxytocin 5 units intravenously may be used. Another option is a combination of oxytocin 5 units plus ergometrin 500 microgram intramuscularly, provided there is no contraindication to ergometry. Now, there is another very useful practical point. If intravenous oxytocin is being used in a woman, oxytocin during labor, slow intravenous injection over approximately 3 to 5 minutes. And after cesarean birth, NICE recommends offering carbetocin but slow injection for prevention of PPH. So these are not random numbers. For the exam, link drug and route and timing together. Oxytocin 10 units or IM or 5 units IV, and oxytocin plus ergometry 5 units plus 500 micrograms ergometry IV. And always think about whether ergometry is contraindicated or not. Am I clear so far? Now let's talk about the cord clamping, because it's another area where older practice and current documentation can easily get mixed up. First principle, give the uterotonic before cord clamping. After administering the uterotonic, do not routinely clamp the cord earlier than 1 minute after birth. So routine immediate cord clamping is not recommended. There are, however, some exceptions. Earlier clamping may be required if there is concern about the cord integrity, or if the baby has a heart rate below 60 beats per minute that is not improving, and immediate neonatal management is required. Otherwise, in active management, clamp the cord before 5 minutes so that the control contraction can be performed as part of the management of the third stage. But what if the woman specifically requests cord clamping later than 5 minutes? Again, share decision making, discuss it, and support her choice where clinically appropriate. And don't forget documentation. Record the timing of the cord clamping. So here is a memory line. First, get the uterotonic. Don't really clamp before 1 minute. Clamp before 5 minutes for active management. That sequence is very exam friendly. Next comes control cord traction or CCT, and the word I want to focus on it is controlled. That is not simply pulling on the umbilical cord after the baby has been delivered. Control cord traction should be performed only after the appropriate prerequisites have been met. First, the uterotonic has been administered. Second, the cord has been clamped and cut. And third, there are signs of placental separation. Only then should controlled contraction be performed using the appropriate technique. This distinction is important because uncontrolled traction of the cord can cause serious complication. So if an exam question describes a baby just delivered and asked whether you should immediately pull on the cord to deliver the placenta, the answer is no. Wait for the appropriate sequence. Uterotonics, then give do cord management, then see the evidence of placental separation, then do controlled cord traction, not random traction, not forceful traction, and definitely not immediate uncontrolled pulling. Am I clear so far? Finally, what happens if the woman initially chooses physiological management? Remember, the management plan is not fixed forever. Clinical situations may change the conditions. Advise a change from physiological to active management if hemorrhage occurs. That makes sense because active management reduces bleeding-related morbidity, and we now have an immediate clinical reason to intervene. And also advise changing to active management if the placenta has not been delivered within 1 hour of birth. That 1 hour threshold is worth remembering. You can also offer a change to active management if the woman herself decides that she wants to shorten the third stage. So physiological management does not mean we have chosen physiological management, therefore we can never intervene. Absolutely not. We continuously reassess. And another useful negative recommendation, do not routinely use umbilical oxytocin infusion and do not routinely use prostaglandins and otherwise normal management of third stage. So the final message from this section is be flexible, keep assessing maternal choice, but intervene when clinical safety requires it. And our major exam number here is that in physiological management and placenta not delivered within 1 hour, advise change to active management. So now we have covered the topic, basic management of the third stage, active versus physiological management, uterotonics, timing of cord clamping, and controlled cord traction. But the third stage becomes much more clinically important. When things do not go according to the plan, what if the placenta does not deliver? When exactly do we call it a prolonged third stage? And when does a retained placenta require intervention? So, when is third stage is prolonged? The third stage is prolonged when the placenta is not delivered within 30 minutes, and active management aims for quicker delivery of the placenta to reduce the risk of PPH, or physiological management, the placenta is not delivered within 60 minutes. So this is called that the third stage is now prolonged. It is an emergency that the placenta is retained. Now what? So it is an important complication of third stage. Once placenta is retained, our management needs to become more structured because the longer the placenta remains undelivered, the greater our concern regarding hemorrhage and maternal duration. The first step is to secure an IV line and importantly, explain when exercise is required. Now, here comes an important nice recommendation. Do not routinely use umbilical vein agents for a retained placenta. And do not routinely give intravenous oxytocin agents solely for the purpose of delivering a retained placenta. This distinction is important. You may think the placenta is retained, so let me start IV oxytocin to get it out, but that is not routinely recommended just to facilitate placental delivery. However, and this is an important exception, if the woman has a retained placenta with excessive bleeding, then intravenous oxytocin agents should be given. So remember the distinction. Retained placenta alone does not mean don't routinely use IV oxytocin simply to deliver it. Retain a placenta and excessive bleeding means give IV oxytocin agents and manage the hemorrhage simultaneously. That is a very useful SV distinction. Before we discuss the management of postpartum hemorrhage, I want you to understand something fundamental. PPH assessment is dynamic. A woman may enter labor without major antenatal risk factor and then acquire important risk factors during labor. So risk assessment should continue throughout the labor. Examples include induction or augmentation, particularly with oxytocin or prostaglandins at prolonged first or second stage also increases the risk. Then we have sepsis, oxytocin exposure during labor at the opposite extreme precipitated labor. Operative interventions matter as well, forcible venatose and cesarean birth. Shoulder dystocia is another importance, right? So we need to manage that. Now, if there is retained placenta and now we have to do membrane removal, if there are concerns for the maternal condition, then we have to do vaginal examination to assess the need for membrane removal. Then explain that examination may be painful. Offer appropriate analgesia, and if analgesia is inadequate, stop and reassess immediately. And if she's not already in obstetric unit, transfer her to the obstetric leg care as soon as possible. Never do you try an exploration membrane removal or placenta without anesthesia. It is very painful for the patient. Now, there are certain risk factors for PPH. Recommend birth in obstetric risk factor if any of these risk factors are present. For example, if there's previous PPH more than 1 liter, if there's placenta accreta spectrum, if there is preeclampsia, or patient has HB of less than 8.5, or she is obese, BMI more than 35 kg per meter square, or she is grand multiparity more than 4 babies, APH, PPH, APH, placenta abruption, uterine over distension due to multiple pregnancy, polyhydramnios, or uterine abnormalities, or low-lying placenta, then these are the risk factors which and you should recommend for. Now, these are the risk factors I was intervention, a prolonged first then we have oxytocin exposure during labor and the so don't read the PPH testing per minute. Am I correct? Technical glitch, I guess there's some points were missed. I'm again recapping it. A placenta is retained, secure IV line, explain why it is required, and do not use umbilical vein agents and IV oxytocic agents solely to deliver the placenta. But if the patient is bleeding, you can give IV oxytocic agents. Plus, if there are concerns about the maternal condition, then vaginal examination to assess the need for manual removal. Then explain the patient that examination may be painful. Now offer appropriate analgesia, and if analgesia is inadequate, stop and reassess immediately. And if already patients not in obstetric unit, that transfer the patient to obstetric care as soon as possible, and never do exploration of manual removal of placenta without anesthesia. It is very, very painful for the patient. Plus, I discussed some of the PPH risk factors and individual risk factors that in with the situation, what is recommended in obstetric unit if there's previous PPH more than 1 liter, if there's placenta accreta spectrum, preeclampsia, HB less than 8.5 at the onset of labor, if patient is obese, BMI more than 35 kg per meter square, if there's grand multiparity, antepartum hemorrhage, placental abruption, uterine over distension due to multiple pregnancy, polyhydramnios, uterine abnormalities, and low-lying placenta. then recommend birth in obstetric unit. And then I discuss certain intrapartum risk factors that include risk factors that arise during labor that may be previously normal, like induction augmentation or prolonged first or second stage, or patient may have sepsis or oxytocin used during labor or precipitated labor, forceps of venereal birth or cesarean birth or shoulder dystocia. So these are the factors that may arise, and these are the risk factors that are usually for PPH. Am I clear so far? If there was glitch and in case you missed out, so I have revised that. So that is a very important clinical message that PPH assessment is not a one-time checklist. Keep reassessing. So if PPH happens, now what you have to do? First of all, you have to call for help. Shout करते हैं PPH हो गया है. Now PPH has happened. What is your immediate management? Call for help. Senior staff, senior obstetrician, anesthetist. So everyone, sure macha do PPH ho gaya, and do the immediate management treatment that includes empty the bladder, uterine massage, uterotonic drugs, IV fluids, and control contraction if placenta not delivered. At the same time, continue to assess the blood loss. Monitor the maternal condition by pulse, BP, respiratory rate, saturation, consciousness, output, catheterizer. Identify the source of bleeding. 40s, the tone, the trauma, the tissue, the thrombin, and consider supplementary oxygen when required. And arrange the transfer to obstetric care. You have to resuscitate the patient, identify the cause, and treat the cause simultaneously. Am I clear so far? Now, a quick but important point about oxygen and PPH. In a woman with significant PPH who requires supplementary oxygen, high concentration oxygen can initially be delivered using a non-rebreathing mask of the reservoir, for example, around 15 liters per minute, while assessing and resuscitating her. The usual oxygen saturation target in an actually ill adult without a specific risk of hypercapnic respiratory failure is around 94 to 98%. But here is the important principle. Oxygen does not treat the hemorrhage. Giving oxygen while the woman continues to bleed is not definitive management. At the same time, you must control the source of bleeding, restore the circulating volume, monitor hemodynamic status, and escalate appropriately. So think of oxygen as a part of supportive resuscitation when indicated, not as a substitute for hemorrhage control. And clinically, don't delay things that actually save a life. Calling for help, controlling bleeding, securing IV line, blood sampling, fluids, and blood products when indicated. Now, if PPH is due to uterine atony, the choice depends partly on which uterotonic was already given for third stage prophylaxis. If no prophylactic uterotonic was given, first line is oxytocin plus ibuprofen IM. If it is contraindicated, you can give carboprost IM or oxytocin infusion as soon as IV access is available. Further options that carboprost IM is contraindicated in asthma and some cardiac conditions, so make sure that you have ruled out the contraindication. Also, misoprostol is useful when other uterotonics or are unavailable or ineffective. Now let's revise two very exam-friendly uterotonics, carboprost and misoprostol. For carboprost, the dose you need to remember is 250 micrograms intramuscularly. It may be repeated at intervals of not less than 15 minutes with a maximum of 8 doses. And so the memory sequence is carboprost 250 micrograms, IM, minimum 15-minute interval, maximum 8 doses. But whenever you hear carboprost, your next thought should be asthma. Carboprost is a prostaglandin F2 alpha analog and can cause bronchospasm. So it should be avoided in women with asthma. Also use caution, avoid in certain significant cardiac condition. Now misoprostol. The dose shown here is 800 microgram, given sublingually or rectally in the context of PPH management. Misoprostol can be particularly useful where other uterotonics or IV access are unavailable, depending on the clinical situation and local protocol. For the exam, lock in these associations. Carboprost 250 microgram IM, 15 minutes, maximum 8 doses. Misoprostol 800 microgram. These drug dose contraindication combination are exactly the kind of thing that gets turned into an exam question. Now we talk about tranexamic acid in PPH. This is very, very important. If we talk about transamine use in PPH. Remember, transamine or tranexamic acid is not a uterotonic. It is an antifibrinolytic. It reduces the breakdown of fibrin clots and therefore helps stabilize clot formation while we are simultaneously treating the source of hemorrhage. In a woman with PPH, give tranexamic acid 1 gram IV over approximately 10 minutes, in addition to the rest of the PPH management. And clinically, tranexamic acid should be given early. Don't wait until the woman has catastrophic hemorrhage. Another important timing point is that the benefit is greatest when tranexamic acid is given within 3 hours of birth. Now, suppose bleeding continues. A second 1 gram dose can be considered if bleeding continues after around 30 minutes, or if bleeding stops and then restart within 24 hours. So the exam memory should be PPH, tranexamic acid 1 gram IV over 10 minutes, give early, ideally within 3 hours. Am I clear? So I hope that some points have retained in your mind. PPH, tranexamic acid, 1 gram IV over 10 minutes, give early, ideally 3 hours of blood, persistent bleeding. Consider second 1 gram dose after 30 minutes. And one more thing, tranexamic acid does not replace with tonics, resuscitation, or hemorrhage control. It is an additional treatment. So while tranexamic acid is going in, you are still treating tone, trauma, tissue, and thrombin. Now imagine we have called for help. We have started tranexamic acid. This is the point where you must escalate rapidly. If available, consider near patient population testing. Why? Because major hemorrhage can rapidly produce or worsen the coagulopathy, and treatment may need to be guided accordingly. So consider appropriate blood products, including packed red cells and clotting products, according to the woman's clinical condition, laboratory point of care results, and the major hemorrhage protocol. But while correcting the circulation coagulation, you still need to answer one question. Where is the blood coming from? This woman may require an examination under anesthesia. Am I clear so far? This woman may require an examination under anesthesia. You need to make sure that the uterus is empty because retained placental tissue can maintain hemorrhage, and carefully examine the genital tract. Any significant cervical, vaginal, perineal trauma needs to be identified and repaired. So again, return to the 4Ts, the tone, the trauma, the tissue, and the thrombin. Now, if the uterine atony persists despite appropriate medical treatment, consider uterine balloon tamponade before moving to more invasive surgical options where clinically appropriate. So this is an important escalation step. Think persistent PPH, resuscitate, correct coagulopathy, exclude the retained tissue, trauma, balloon tamponade, escalate to surgery if bleeding remains uncontrolled, and don't spend too long repeating ineffective medical treatment while the woman continues to deteriorate. PPH management requires early recognition of treatment failure and timely escalation. Now, this slide is different from all the previous slides, but clinically it is just as important. During a postpartum hemorrhage, the room can suddenly become extremely busy. People are calling for blood. Someone is obtaining IV access. Someone is giving medication. Then a static team may arrive. The obstetric team may be examining the woman, and imagine what all of this looks like from the patient's perspective. She's just given birth, and suddenly there are multiple people around her, alarms, urgent conversations, and procedures, and she may have absolutely no idea what is happening. So during the emergency, allocate a healthcare professional where possible to stay with the woman and a birth companion, and their role is simple but incredibly important. Explain what is happening, answer the questions, and provide continuous reassurance and support. We sometimes become so focused on saving the patient's life, the communication unintentionally disappears. But emergency treatment and respectful maternity care are not competing priorities. They should happen together. And after the acute event, she should also have an opportunity to understand what happened, what treatment she received, and what it means for her recovery and future pregnancy. Because surviving an obstetric emergency is not only a physical experience, it can be psychologically overwhelming as well. Okay, guys, before we finish this section, let's do one final high yield numerical recap. These are exactly the numbers I want you to carry into your SB exam. First, oxytocin during labor. When increasing oxytocin, increase it no more frequently than every 30 minutes and aiming for approximately to 4 contractions in 10 minutes. Then instrumental birth, remember that the recommendation for IV prophylactic antibiotic within 6 hours after forceps or vacuum. Then prolonged third stage, this one is extremely important. Active management 30 minutes and in physiological management 60 minutes. Then cord clamping, do not routinely clamp the cord before 1 minute after birth. And when active management of the third stage is being used, clamp before 5 minutes so that controlled cord traction can be performed. Then PPH risk factors, remember some important numbers, that PPH greater than 1000 ml, hemoglobin below 8.5 gram per deciliter at the onset of labor, and be parity of 4 or more. If PPH occurs, don't management as a long linear list. Think and identify and treat the cause simultaneously. Then keep the 4 T's running in your head: the tone, trauma, tissue, and thrombin. 250 microgram IM. Repeat. I absolutely want you to remember is tranexamic acid. IV over 10 minutes, give it early. Ideally, that we these every number to a clinical situation, because one the clinical story behind the and that comes of labor, retained placenta, and postpartum hemorrhage. If there's one message I want you to call for help early, don't shy, resuscitate aggressively, identify the cause, treat the cause, and escalate before the patient deteriorates. Okay. Now that we have completed maternal care around birth, let's shift our attention to the newborn. And that the first thing to understand is that assessment of the baby starts immediately after birth. For every birth, record the APGAR score at 1 minute and 5 minutes. These are two very important exam numbers, APGAR 1 minute and 5 minutes, and also, but don't just record the APGAR score, also document the time from the birth until the onset of regular respirations. Now, if the baby is born in poor condition, don't wait for an APGAR score before taking action. Assessment and resuscitation happen simultaneously according to the neonatal resuscitation guidance. And assessment continues until the baby is stable. Now, look at the right side of the slide. Because there is subtle examination point here, when assessing the color, particularly central oxygenation, look inside the mouth. Don't rely on the hands and feet. Look inside the baby's mouth, particularly at the mucous membrane and baby's mouth, particularly at the mucous membrane and the tongue. Why? Because peripheral color can be misleading immediately after birth. So for an exam question, central color, think mouth and tongue. Whereas peripheral oxygen color, neighbors. So your take-home messages APGAR at 1 and 5 minutes, and central color is assessed centrally, particularly the mouth and tongue. Now here's a very nice exam trap. Should we baby, but if the baby condition, cord blood gas analysis may be indicated. And when you need paired cord gases, remember the practical point: a segment of cord needs to be isolated using 2 clamps so that appropriate samples can be obtained. That is why second clamp should be readily available in every birth setting. So if an exam question says normal delivery, baby crying, good tone, normal heart rate, should pair cord gases routinely be obtained? Answer is no. But if the baby is significantly compromised at birth, then paired cord blood gases may become clinically important. So in routine birth, no routine paired cord gases, but in poor condition baby, consider paired cord gases where indicated. Am I clear so far? Now we talk about something simple but incredibly important: skin to skin contact for a healthy mother and a healthy baby. Encourage skin to skin contact as soon as possible after birth. And skin to skin contact is not simply about bonding. It helps maintain the baby's temperature, facilitates early breastfeeding, and supports physiological lactation after birth. During skin to skin, make sure that the baby is dry and covered appropriately with a warm, dry blanket or towel. Maintain warmth throughout. But there is one safety point you must never forget: airway position. The baby's head must be supported and positioned so that the airway remains patent. We want skin to skin contact, we want safe skin to skin. And there is a lovely patient centered point. If the mother is not well enough to provide skin to skin immediately, the birth companion may provide skin to skin instead when appropriate. So remember, skin to skin as early as possible, warmth, drawing, and airway safely throughout. Now, this slide is extremely important. Clinic, think of the first step for the mother and the baby. Unless there is avoid unnecessary separation. This is weighing, major, nothing should not automatically interrupt because an immediate priority is bonding, skin to skin, and initiation of breastfeeding. As possible after birth. So imagine a quite stable baby is skin to skin and beginning to breastfeed. The staff member wants to remove the baby immediately simply to obtain the weight. Do we need to interrupt skin to skin just for routine weighing? No. Routine measurements can generally wait. After the initial period, record the baby's birth weight, measure the head circumference, plot measurements appropriately, check the temperature, and perform the initial examination for major physical abnormalities. So remember the sequence that the first hour is for mother and baby together whenever possible, warmth plus bonding plus breastfeeding. Then routine measurements and examination. Now, we move into neonatal resuscitation. And before thinking about complicated algorithms, start with 3 simple questions. Immediately after birth, assess the respiration, the heart rate, the tone. Is the baby breathing adequately? What is the heart rate and does the baby have good tone? If resuscitation is required, call for help early and follow accredited neonatal resuscitation guidance. Now, here is another important point highlighted in NICE. If basic resuscitation is required, start with air rather than automatically giving high concentration oxygen. That's an important conceptual shift. More oxygen is not automatically better for every newborn. And while the clinical team is resuscitating the baby, communication must continue. Minimize unnecessary separation where possible. Allocate somebody to explain to the woman and her birth companion what is happening, why is the baby being treated, what are we doing now. Again, the same principle we discussed during the PPH applies here. And emergency does not cancel communication and respectful care. Now, another point. We come to meconium, and this is a very beautiful area for SBA trap. I hope that up till now you have been clear. Historically, meconium often triggered immediate suctioning, but remember current practice, meconium does not automatically mean suction. With any degree of meconium, do not suction the baby's upper airway before the birth of the shoulder and trunk. Now, once the baby is born, assess the respiration, assess the heart rate, assess the tone. If these are not, do not routinely suction, do not intubate simply because meconium was. If these are not equal automatic action, abnormal heart rate, the neonatal resuscitation pathway. So don't memorize meconium. No baby is unwell, neonatal resuscitation pathway. That distinction is very friendly. Now, suppose the baby has been born throughout the significant meconium but appears well after birth. Are we finished? Not quite. The baby requires observation in a setting where neonatal expertise is readily accessible. And now come the numbers. For significant meconium, assess the baby at 1 hour, at 2 hours, and then every 2 hours until 12 hours of age. So 1, 2, then 2 hourly until 12. For non-significant meconium, observation is less intensive. 1 and 2 hours. What findings to trigger neonatal assessment after? Okay, this was because they are is heart less than 100, more than 160 per minute, or capillary refill more than 3 seconds, or temperature more than 38 degrees Celsius, or a temperature of around 37.5 degrees Celsius on 2 occasions 15 to 30 minutes apart, or oxygen saturation below 95%, or central cyanosis. So don't try to memorize these as random numbers. Think of 4 systems: the breathing, the circulation, the temperature, the oxygenation. And the high yield boundaries are if the respiratory rate 60, heart rate 100 to 160, capillary refill time is 3 seconds, or saturation 95%. Anything crossing those concerning thresholds after meconium should make you think that this baby needs neonatal assessment. Am I clear so far? Now let's connect neonatal care with something we discussed earlier in the maternal section, the term pre-labor rupture of membranes. Suppose the membranes ruptured more than 24 hours before the onset of established labor at term. What do we do with the baby after birth? The important point is close observation during the first 12 hours. The recommended assessment timings shown here are 1 hour, 2 hours, 6 hours, 12 hours. This is a very easy SVS sequence to forget. So memorize is as 1, 2, 6, 12. Term from greater than 24 hours, newborn observation during the first 12 hours with assessment at 1, 2, 6, 12 hours. The reason, of course, is concern about the early onset neonatal infection. But, and this becomes important on the next slide, increased risk does not mean that every asymptomatic baby automatically receives antibiotics. So what exactly are we looking for during these observations? We are looking for early evidence that the baby may be becoming unwell. Assess the temperature, assess the heart rate, check the respiratory rate, look for grunting, look for significant subcostal recession or increased work of breathing, assess for nasal flaring, assess for central cyanosis, check capillary refill time, skin perfusion, assess the baby's tone, is there any floppiness, look at the baby's overall clinical well-being, and very importantly, how is the baby feeding? Because poor feeding may be one of the early clues that a newborn is becoming unwell. Well, this is not simply take temperature 4 times. No, it is a proper clinical assessment of the newborn. If any of these parameters are abnormal, arrange appropriate neonatal assessment and manage according to the neonatal infection pathway. And here is the observations that we have discussed. Now, the other thing is the biggest SVA trap in this section memory for more than 20 hours has now been no need antibiotics? No. Do not give antibiotics simply this are not automatically clear. Am I clear so far? Risk factor does not automatically equal the treatment. Instead, observe the baby appropriately and assess for clinical indicators of infection. If there is evidence suggesting neonatal infection, then follow the appropriate early onset neonatal infection guidance. Similarly, in an asymptomatic baby, don't automatically start doing every possible investigation simply because PROM has exceeded for more than 24 hours. Routine blood cultures, CSF cultures, or surface cultures are not automatically indicated in an otherwise well baby solely because of prolonged rupture of membranes. So here's the exam sentence I want you to remember. From more than 24 hours alone is not automatic neonatal antibiotic indication. If the baby becomes symptomatic, that's different. Then you investigate and treat according to the neonatal infection pathway. So in an exam, always distinguish risk factor only from the clinical evidence of infection. That one distinction can change the entire answer. Okay. Before leaving newborn care, let's rapidly lock in numbers. Apgar at 1 at 5 minutes, significant meconium, assist at 1 hour, 2 hours, then 2 hours in the 12 hours, non-significant meconium at 1 and 2 hours, meconium red flags are respiratory rate more than 60, heart rate below 100 or above 160, capillary refill time above 3 seconds, saturation below 95, and after term from greater than 24 hours, observed during the 12 hours, the assessment at 1, 2, 6, and 12 hours, and the PrEP from more than 24 hours does not mean automatic neonatal antibiotics. These are exactly the small guideline details that can turn into very straightforward exam questions once you know what the examiner is looking for. Okay, now we have discussed the immediate care of the baby. Let's turn our attention back to the mother. Remember, delivery of the baby and placenta does not mean that maternal care is complete. The immediate postpartum period is extremely important because this is where we may first recognize hemorrhage, hemodynamic instability, urinary retention, or other complications. So immediately after birth, record the basic maternal observations, the temperature, the pulse, the blood pressure, the respiratory rate. But please don't make the mistake of thinking postpartum assessment means only checking vital signs. We also need to assess the uterus, assess the lochia, assess the vaginal blood loss, and very inspect the placenta and membranes for completeness. Why? Because an incomplete placenta or retained placental tissue may contribute to postpartum hemorrhage and requires appropriate obstetric assessment. So, if the placenta appears incomplete, this is not something to simply to document and ignore. The woman should be transferred or referred to obstetric-led care as appropriate. Then assess the bladder function. Has she passed urine? Is the bladder palpable? And finally, don't forget something that sometimes gets left out of purely clinical checklist: her emotional and psychological well-being. Ask how she feels. Explain what has happened. Give her an opportunity to ask questions. So immediate postpartum assessment is not just BP pulse done. It is vitals plus uterus plus bleeding plus placenta plus bladder plus psychological well-being. Now here comes our first important number, 6 hours. After birth, make sure the woman has successfully passed urine. Why do we care? Because postpartum urinary retention can occur due to perineal trauma, edema, pain, regional analgesia, and altered bladder sensation after labor. Now, suppose 6 hours after birth, the woman still cannot pass urine and her bladder is palpable. What should you do? This needs active management. Advise catheterization, and depending on the clinical setting and circumstances, consider transfer to obstetric-led care. This is a lovely question because the examiner will simply give you 6 hours following vaginal birth, the woman has not passed urine and has a palpable bladder. That should immediately trigger postpartum urinary retention. Don't keep telling her to drink more water and wait indefinitely. Distended bladder is not harmless. It can cause significant discomfort, contribute to bladder dysfunction, and can also interfere with effective uterine contraction. So your memory line is very simple. After birth, bladder, remember 6 hours and keep that number in your mind because on the next slide, I'm going to give you another number that students commonly confuse with this one. Okay, now here's that second number, 4 hours. And please don't mix these two numbers. In bladder, 6 hours and regional analgesia, 4 hours. After regional analgesia or anesthesia, we need to make sure that neurological motor function is recovered appropriately. One simple assessment is the ability to perform a straight leg raise. Patient se tange uthaye apni. And this should be checked by 4 hours after the last dose of regional analgesia. If she can perform a straight leg raise appropriately, that's reassuring. But what if 4 hours have passed and she still cannot perform a straight leg raise? Don't simply assume that epidural is probably still working. She needs urgent review by the obstetric anesthetist. Why? Because persistent motor weakness after regional anesthesia requires assessment rather than being automatically attributed to the expected effect of anesthesia. This is very high yield. So, in 4 hours, regional analgesia and 6 hours for bladder. So, now once the mother is hemodynamically is stable, we have assessed the bleeding, the bladder, and recovery from regional analgesia. Another essential part of postpartum care is assessment of the perineum. And before you can manage a perineal tear correctly, you have to classify it correctly. So let's quickly revise the classification because this is the absolute exam code. First principle, whenever you assess a perineal tear, identify the apex of the tear and assess the full extent of the trauma carefully. Now, let's classify it. First degree tear. A first degree tear involves the skin only. No perineal muscle involvement. So first degree is only skin. Simple. Second degree tear extends deeper and involves the perineal muscle. But here's the important distinction. The anal sphincter is not involved. So second degree is perineal muscle, but no anal sphincter. Now we come to the third degree tear, and this is where your SBS really begins. A third degree tear involves the anal sphincter complex, and we divide it into 3A, 3B, 3C. 3A in less than 50% of the thickness of the external anal sphincter is torn. 3B, more than 50% of the external anal sphincter is torn. 3C is that internal anal sphincter is also torn. So whenever you see internal anal sphincter, think of 3C. And finally, 4th degree tear. A 4th degree tear extends through the sphincter complex and involves the anal epithelium or anorectal mucosa. So 4th degree is not simply a very bad degree tear. The defining feature is extension through the anal sphincter complex into the anal epithelium or anorectal mucosa. Now let's flop the whole classification into one end. First, skin. Second, perineal muscle. 3A, less than 50% of external anal sphincter. 3B, more than 50% of external anal sphincter. And 3C, internal anal sphincter involved. And 4th, sphincter complex for an epithelium. And one more thing, if you're uncertain whether there is a 3A, B, identification matters because inadequate injuries can have significant long-term consequences for the mother. So whenever you are assessing perineal trauma, identify the prepare appropriately and manage it thoroughly. Okay, now moving towards another slide. Now that we know how perineal trauma is classified, the next question is how should we assess it properly? And remember, this examination is intimate and may be uncomfortable, particularly immediately after birth. So technique and communication matter just as much as identifying the tear. So before examination, explain to the woman what you are going to do and why. Offer appropriate analgesia. Inhalation analgesia can be offered if required. Make sure you have good lighting, position the woman comfortably, and ensure the genital structures can be clearly visualized. The examination should always be performed gently and sensitively. And yes, assessment can be performed in the immediate period after birth when appropriate. So don't rush into examining a tear just because you have seen some bleeding. First, explain, give analgesia, have good lighting, position the woman gently in adequate visualization. Respect and dignity remain part of good clinical care, even when we are dealing with an urgent obstetric situation. So now this is an important concept. After vaginal birth, women should be offered a systemic assessment of genital trauma. And when indicated as part of that assessment, a rectal examination is important. Because visual inspection alone may underestimate deeper trauma. What are we trying to establish? We want to identify the full extent of genital tract trauma and importantly detect injuries that may otherwise be missed, including a rectal buttonhole tear and possible anal sphincter injury. Am I clear? So remember what tear each the even when the anal sphincter itself is in, there may be injury to the rectal mucosa even when the anal sphincter itself is intact. This is called a buttonhole tear. So we have to exclude that. Don't assume that a relative perineum can you. There is concern about or rectal involvement. You need an appropriate rectal assessment. Missing an obstetric anal sphincter injury at the initial examination can have important long-term consequences for the woman. Now, let's make the examination systematic rather than simply looking at the perineum saying second-degree tear. First, explain the woman again and make sure the woman has effective analgesia. Then visually assess the full extent of the trauma. Ask yourself which structures are involved: skin, vaginal mucosa, perineal muscle, external anal sphincter, internal anal sphincter, rectal mucosa. Then identify the apex of the injury. This is extremely important. If you have not identified the apex, you have not adequately defined the extent of the tear. And assess the amount and source of bleeding as well. And where sphincter damage is suspected, perform an appropriate rectal examination to assess the sphincter complex and rectal mucosa. So your assessment is not simply this is a tear. It should answer three questions. How far does it extend? Which structures are involved? And where is the apex? Once you know these three things, you can classify and repair appropriately. Now, don't interrupt bonding unnecessarily. This is equally important. This recommendation because it reminds us that obstetric care is not just a list of procedure. Immediately after birth is an important time for mother-baby bonding and skin-to-skin contact. So time your systematic assessment so that it does not unnecessarily interfere with the bonding. Are you getting me? Notice the word unnecessarily because there is an obvious exception. Bleeding requires urgent attention. If the woman is actively bleeding and needs assessment or treatment, obviously maternal safety take priority. But in a stable woman, don't separate mother and baby or prolong an uncomfortable position simply because it's convenient for us. Use a position that provides adequate visualization for accurate assessment and repair, but maintain that position only for as long as necessary. That's good obstetrics. Safe care without forgetting dignity, comfort, and the birth experience. Now, when to call for senior help? That's very another important clinical point. Know when not to continue alone. If you are uncertain about the nature of the trauma or uncertain about the extent, seek advice from an experienced midwife or obstetrician. And if adequate assessment simply is not possible in your current setting or the repair requires additional surgical and aesthetic expertise, transfer the woman to obstetric care. This is not failure. Trying to repair a tear that you have not adequately assessed is much more dangerous than asking for help. And once assessment is complete, document your findings fully. A diagram can be extremely useful because it communicates exactly where the injury was. And if there's uncertain injury, call for help. Unable to assess adequately obstetric additional anesthetic expertise. Now, okay, now first principle the soon as possible. Timely repair helps minimize loss, reduce complications. And before you put in even a single stitch, ask, is my analgesia active? Anaesthesia and immediately start suturing. So the has Am I clear? And for local infiltration, you can use 20 ml of 1% lidocaine. Am I clear so far? Or an equivalent local anesthetic regimen may be used according to the relevant guideline and clinical context. Remember that number for the exam, 20 ml, 1% lidocaine. If she surely has an epidural, this may be topped up when appropriate. And if required, regional analgesia, such as spinal anesthesia, may be necessary depending on the injury and setting. But here is a principle I want you to remember more than any particular drug. Pain during repair is not something women should simply tolerate. If analgesia becomes inadequate at any point, stop and assess it immediately. Don't tell her, bas thoda sa reh gaya. No, adequate analgesia is a part of. Now, here is a nice exam trap. A first degree tear involves the skin only. Students sometimes memorize that first degree so don't suture. That's too simplistic. Generally, suturing may be used to improve healing, but if the skin edges are already well opposed, suturing may not be necessary. So the decision is not based simply on the label first degree. Look at the wound. Are the edges opposed? Is there bleeding? Will approximation improve healing? Therefore, first degree tear does not automatically mean leave it unsutured. That's a trap. Second degree trauma is different because now the perineal muscles are involved. And those muscles should be sutured. Why? Because approximation of the muscle layer promotes proper anatomical healing. Now, here comes another important distinction. After you have repaired the muscle, look at the skin. If the skin edges are already well opposed, you don't necessarily need additional skin sutures. But if the skin requires suturing, use a continuous subcuticular technique. So remember, second degree muscle repair it, and skin only needs if not adequately opposed. That distinction is much more useful than simply memorizing repair a second degree tear. Now, this slide is pure SPA material, so let's slow down here. For the vaginal wall and muscle layer, the preferred technique is continuous non-locked suturing technique. Let me repeat. Vagina and muscle, continuous non-locked. Why do I emphasize non-locked? Because students often remember continuous but forget whether it should be locked or non-locked. Then for the skin, if the skin suturing is required, continuous subcuticular technique. So now we have two different techniques, vagina and muscle continuous non-locking and skin continuous subcuticular. And what about suture material? Use and absorb the synthetic material. You don't need to make this complicated. Your exam memory line is between vagina and muscle continuous non-locked and skin में continuous subcuticular. And material कौन सा? Absorb the synthetic. If exam question give you several combination of locked, interrupted, subcuticular, and continuous technique, this little 3-line rule should help you pick the correct answer. And remember, what we are ultimately trying to achieve here is not the prettiest looking sutures. Our goals are good anatomical approximation, good healing, less pain, and better long-term outcome for the woman. Okay. Before we move on one very small but clinically important point, don't forget analgesia after repair. First or second degree trauma offer a rectal NSAID routinely, provided there is no contraindication. And this is actually a very easy thing to forget in a question because our attention is usually focused on how the tear was repaired. But management does not finish with the last stitch. The woman still needs adequate post-repair pain relief. So remember, simple point, definitely worth remembering for. Now, before close, of Whatever the degree of trauma you are repairing, good surgical principles still apply. Use an antiseptic aseptic technique. You have to then make sure your equipment is complete before starting, and very importantly, count your swabs and needles before and after the procedure, please. You definitely don't want a routine swab after what was a ensure adequate anesthesia and perform the repair in an appropriate setting. And ultimately, what are we trying to achieve? Not simply closing a wound. We want to restore good anatomical alignment, muscle, which anal tissue should be approximately approximated, and the final repair should give the woman the best possible functional and outcome. So think before the beyond the stitch, anatomy, the function, the healing, and the long-term outcome. Now, another point I really want you to differentiate from the rectal examination we discussed earlier. Because rectal examination can have different purposes depending on when you are doing it. Before we perform a rectal examination to no suture has inadvertently passed through the rectal mucosa. And that's a beautiful exam distinction. If you feel suture material through the rectal mucosa after repair, implementing it and moving on. Before repair, detect the injury, and after repair, check that your repair has not involved the rectal mucosa. And of course, the findings and any concern. Okay, now repair is completed, but our job still is not finished. Before we need proper documentation and counseling. Document the extent of trauma, the suture material used, then explain what happened, tell her the injury, discuss the appropriate pain relief, counsel regarding the hygiene, the diet, your floor exercise, expect during recovery, and don't perineal trauma can be very distressing part of their birth. And now, before we finish, let's do a rapid 3 less than 50% of external anal sphincter thickness involved. 3B more than 50% of external anal sphincter thickness involved. 3C external anal sphincter plus internal anal sphincter, and 4 degrees sphincter complex and rectal mucosa. Assessment should be systematic with appropriate rectal examination for local infiltration. Remember, up to 20 ml for suturing in vagina and muscles, continuous non-lock skin if required, continuous subcuticular, and suture absorb the synthetic. After the second degree tear, consider application. Am I clear so far? If you we need proper documentation, the method of repair, and the suture. Next, tell her the extent of injury and discuss appropriate pain relief. Counsel regarding hygiene, diet, pelvic floor exercise, and tell her about the pain relief. And most importantly, tell her when and where to seek help. And don't forget the psychological side. And before we finish, let's do a rapid exam recap. The 3A, less than 50% of external anal sphincter thickness involved. 3B, more than 50%. And 3C, external anal sphincter plus internal anal sphincter. 4 assessment should be systematic with appropriate rectal or equivalent, and for suturing in vagina and muscle, continuous non-locking suture, and skin, continuous subcuticular suture, and suture material should be absorbable synthetic. And after and there is no contraindication. If you remember this little framework, you have covered most of the higher numbers and techniques from the time. And with that, we finally completed our intrapartum care series. And honestly, this was not a small topic. We have traveled from assessment in labor, maternal fetal well-being, progress of labor, analgesia, interventions, and second stage care, all the way to perineal trauma, repair, and care after birth. That's why you stayed done. So we have finally completed, and if you stayed with me throughout this lecture, well done. You have not simply memorized a guideline, you have built a structured way of thinking about a woman throughout labor, assist properly, recognize problems early, intervene appropriately, and always keep safe, respectful, woman-centered care at the core. This is what I want you to carry into both your exam and your clinical practice. But the story does not end here, because understanding the guideline is one thing, being able to recognize the correct answer when the examiner twists that guideline to a question, that's the next challenge. So our next lecture is going to be 40 high yield SBS on intrapartum care, and I specifically want to target the areas where candidate gets confused, the numbers, the timeline, the threshold, the CTG related decision, the delay in labor, the analgesia, the second state management, and perineal trauma, and those tiny guideline statements that make excellent SPA draft. So don't think of the next lecture as just another set of MCQs. Think of it as learned, real to ourselves. And before I and finally, and finally, I really want to thank you for staying with me throughout the entire series. These lectures take a lot of time and effort to prepare. The that's should keep reading of OBG, yes, to make difficult concepts easier, and hopefully helps us provide better care to our mother and baby. So thank you for appreciating my work, and for remember, keep learning, keep sharing, keep caring. Until then, I'll see you tomorrow in next lecture with higher intrapartum SPAs. Allah Hafiz.